you guys have an idea lah, so that's what we're doing lah. So I want to start out by asking you guys, how will you guys treat this patient? On the left and on the right, how will you start? You guys are dentists already, right? Or everybody are doctors here, so tell me what will you guys do? Will you guys do RCT or you guys just do a feeling? You guys can just react or type in the chat, like you guys are lazy.
Got any complaint? No?
What will you say? Yeah, this patient walked out, the patient say pain. Help me.
Pain.
Pain, yeah, pain. On the left and on the right are both. You're in government setting. So patient walk in, open your mouth, you see a cavity. Or even if, okay, assume it's asymptomatic. Asymptomatic, what will you do?
Oh, wait, assume it's asymptomatic?
Yeah, all asymptomatic. Yeah, what will you do?
Drill.
Drill, right? You drill, right? All of you drill, agree?
Drill.
So left is what? Feeling, right? Right is, both also feeling, right? Left and right.
Government, right? Drill.
Drill, okay, true, right? So these two, extract.
Oh.
Extract or RCT? Or you don't know?
Don't
know. Question, do you know?
Extract, bro.
Right? You Juan, you work government so long, you know how to treat patient. But okay, actually, jokes aside, actually, Juan, you are right. Like, I didn't tell you the diagnosis, right? So how do you know it's extraction or what? Right? I didn't tell any of you, all 4 cases, right? I didn't tell you what's the diagnosis, right? Is it reversible? Is it irreversible? Is it necrosis?
Mm-hmm.
So technically, you shouldn't know how to treat the patient, right? Because you haven't diagnosed the patient yet. Right?
Yep.
That's what I'm trying to tell you. Because if we haven't diagnosed, we cannot treat. We must have an idea what is going on. The diagnosis must come first. So you don't treat before diagnosing. You must know the diagnosis first. Only you proceed with the treatment. So how many of you do calcinol? Like you don't know what to do, you just place calcinol and just bye-bye. So the patient go back 2 weeks later, no pain, then you change to permanent feeding, something like that. You guys do that?
When first started, yes.
That's a typical government thing, right?
Yeah.
But then, actually, in Manipal, I thought even though I don't understand root canals, at least I know what is diagnosis, right? I think that's the easiest thing in Endo. Even though I don't understand anything about RCT, I probably understand a little bit about diagnosis. But it turns out I don't think I understand diagnosis at all. After I attended Dr. Imran's course, that's when I realized, actually, I don't understand diagnosis, so technically I learned nothing in Manipal. I can throw everything away. So I had to restart everything, basically. So that is what's going on. So that's why this topic for today. So what are the diagnoses that we have? Only 7, right? Technically, reversible, irreversible necrosis, symptomatic, asymptomatic, chronic abscess, acute abscess, chronic abscess. So I don't think I'll need to explain to you guys every single thing, right? The symptoms and all, because you guys already graduated. So it's something that we learn in dental school. All of you know this, right? So I just mention it. Okay, so I just assume that you guys know because I don't need to the symptoms and all, which one has lingering, which one has no lingering pain, which one has symptoms, so you guys will know so I don't need to mention anything about that. So how do we diagnose the patient when the patient walks in? What are the 3 steps that we have when we try to diagnose the patient? Because back then I mentioned to you, right, you guys haven't diagnosed yet. So if this patient walk into you, then you don't know, you haven't diagnosed, you start drilling already. So that's what Juwan and Kashan will do. Okay, so you just drill first. But then if you haven't diagnosed, how do you know that the patient actually needs a pulpotomy or RCT? But you wouldn't know, right, if you just assume that the tooth is vital. So that's when it comes to these 3 steps when we diagnose a patient. The first step is localization, is what the patient tells you when the patient walks in. Reproduction is your clinical test, or your co-test, EPT, your tender to percussion, everything. And validation is when you verify the diagnosis from the patient. So these are the 3 steps that we have when we go for diagnosis, which I'll elaborate from now. The first one is localization. This is when what the patient tells you. So it's very typical of Socrates how we ask the patient. But then which one do you think we should ask? Government, we have no time, right? Obviously, you have no time. There are only 2 things that we need to ask. What do you think we need to ask? Can you guys guess which one you need to ask? Actually, everything is not important. Just ask onset and time only. You only need 2 questions. You don't need to ask anything else. Okay, maybe the site lah, but I think that's self-explanatory and the patient will tell you. But if you have no time in government, just ask lah onset. When does the pain? How does the pain occur? Is it random? Is it triggered by cold, hot, or something? Then how long does each session last? That's all you need to ask. You don't need to ask anything else, because the others are not relevant in helping you diagnose, right? Because we don't have time in government. We only have 10 seconds to diagnose every patient. So for our localization, we don't need to ask that many questions if you're rushing. But of course, if you have time, like if you're in private sector, it's good to ask everything because you could be missing something. Or it can be used as a comparison, just like the severity, right? It's not that important in terms of diagnosing the patient, but it's very important if you want to know if the patient's symptoms are improving or not. So that is why we also ask about severity, but if you are rushing like in government, so don't bother, there's no time for that. So the character of the pain, usually if the patient presents with throbbing pain, you will say that it's normally a powerful pain, because only a pulp can give a throbbing pain because of the increase in pulpal pressure. Without the pulp, there wouldn't be any throbbing pain present at all. So if the patient has a necrosed tooth, so you assume, or RCT treated tooth, but the patient tells you throbbing pain, so you have to suspect that something might be wrong with another tooth. It might not be the affected tooth after all, if the tooth is RCT treated, because an RCT treated tooth will not give a throbbing pain. And sharp pain as well is normally pulpal. Or if the patient is a bit confused about the pain, like they say it's discomfort or itchy, it could be periodontal pain, and the other like burning, twitching, numbness normally it's contributed by non-oncogenic pain. So that is but those are very rare lah. So I think I've never met a single one in KKM before having this sort of symptoms. So that's why we stick to the 2 questions. You can handle, I think, 99% of patients in government. So this typical quote, I think you guys see everywhere, right? That if you listen to the patient, he's telling you the diagnosis. But then I'm actually a fan of another quote by House, which I mentioned to you earlier, that every patient lies. So do you actually trust what the patient say when you're diagnosing the case? Like a very textbook classic symptom given by the patient, telling you that, oh, I have lingering pain, oh, I have nighttime pain. But the patient could be lying to you, right? Because you don't exactly know what the patient is telling you. Whether the patient is saying the truth or patient is just exaggerating, you wouldn't know. So should we actually base our diagnosis on what the patient says? I don't think that's what we should do, because number one, the patients could be lying, and number two, your tests that you conduct rely on the patient's response. So you shouldn't rely your decision of a diagnosis based on only what the patient tells you, because there's a very high chance that it's wrong. So how do we reproduce? The second step, the reproduction of the patient's symptoms, which are the pulp sensibility test, percussion test, bite test, and thermal test. So what do we do actually? Remember, we learn all these tests, right? Why do you need to learn so many actually? In undergrad, probably learning to do this, do that, do everything. But actually, it's only one purpose. You want to know exactly what the patient is facing. So if the patient say is pain upon biting, you do a bite test. If the patient say is painful upon consuming coal, then you do cold test, because you want to reproduce the symptoms that was felt by the patient. After reproducing the symptoms that the patient feels, you know exactly which tooth is affected, right? So it actually depends on your first step, when the localization, when the patient tells you what is wrong, then you will try to reproduce the symptoms in your clinical setting. Whatever triggers the pain, where the patient informs, you do it on the patient. Whether it is your cold test, your percussion test, or your bite test. If the patient say pain only upon hot drinks, then you do a thermal test. So actually that's how it's supposed to work. It's not just blundering any single test for the patient. Usually it is because you want to reproduce the symptoms that was felt by the patient during the chief complaint. So percussion test. So do you guys do this? We do this a lot, right? In government. You just tap the tooth randomly. But do you think percussion actually tells you anything? Percussion tells you that you need to do RCT, or percussion tells you that you need to do a feeling. Do you think that is how percussion works? I know the textbook tells us that if it's a pulpal symptom, they wouldn't be tended to percussion. But I think based on experience, you know, right? Percussion actually tells you nothing. But percussion can only tell you which tooth is affected. So if you tap the tooth, that tooth is giving symptoms, so you know something is wrong with that tooth. But it doesn't tell you how to treat the tooth. So you don't know anything about the diagnosis just because of your percussion. But you can localize the pain, or you can localize the problem that is being faced by the patient. So that's what percussion is for. The second one would be pulp sensibility tests. Remember in undergrad, our lecturer always mentioned cold test is more accurate than EPT. You guys ever wondered why? Or do you guys know why is cold test more accurate than EPT? Is there a reason that we should? Because in undergrad, I used to think EPT is better because EPT is when patient symptoms are more. Patient can usually respond to EPT, but cold test sometimes if it's not cold enough, the patient usually doesn't respond. So why we always heard that cold test is more accurate than EPT? Actually, the main reason is because cold test is a symptom that is felt by the patient. So if cold triggers the pain, cold test is the only thing that reproduces the symptom, because EPT does not reproduce the symptom by the patient, right? The patient will not tell you that, oh, I have electric shock like pain. So that is why only cold test is required. Only cold test can reproduce exactly what the patient feels. So that is why we perform cold test. It's not any other reason. Okay, maybe a second reason that I'll tell you now. Because cold test can also tell you the status of the pulp, whether it's reversible or irreversible pulpitis. But EPT cannot tell you. EPT can only tell you whether the tooth is vital or non-vital. Whether it is in a reversible pulpitis state or an irreversible pulpitis state, only cold test will be able to tell you. So these are the only two reasons why cold test is more accurate than EPT. Because number one, cold test will reproduce the symptoms that the patient experience, and the cold test can tell you whether it's reversible or irreversible. EPT, regardless of the value, it will not tell you exactly the pulp status. It can only tell you that the pulp is alive. That's all. And also a bit about pulpal physiology, where cold test only stimulates the C fibers and all that is why only cold test can give a lingering sensation, but not EPT. So that is why you should do your cold test, but you don't skip. You should do both cold test and EPT. But then what if they contradict? Okay. So first, I would like to say that sometimes if you do a cold test, if the patient may not respond if it's not cold enough. So that is why you actually need to use Endo frost, because Endo frost is colder than your EQ chloride, your cold test that we use in Manipur. So it's very important for us to use Endo frost because of the temperature, and you do it correctly as well. Like the patient's tooth must be dry, and the moment your DSA spray the cold test, you must put it immediately onto the tooth. So you cannot linger because the cold will actually wear off. So there are also some false responses that may occur from testing. So if the patient is anxious, or if there's actually liquefaction necrosis, or you contact the metal restrictions during your EPT. So these are the several reasons that there could be false positive or negatives for your pulp test. So if the EPT versus your cold test contradicts, so I wonder what will you guys follow? If your cold test say vital, if your EPT say vital but cold test say not vital, then which one will you guys follow? What do you guys think? Christian, what do you think? I'm very curious. Or Juan, is Christian even there? Still there?
EPT. I'll just EPT.
Christian, I can't hear you, but it's okay. So if EPT and cold test contradict, so you guys trust EPT, right? If both give contradicting results, which one will you guys trust?
I'll say EPT.
EPT, okay. So actually, but you say cold test is more accurate, right? So why do we trust EPT?
You said to determine if the tooth is vital or not, right?
Yeah.
Because you mentioned that EPT test if the tooth is vital or not. Only
No,
can
that's not
determine.
Actually, it's just very simple, because there's this study that says that EPT has a higher positive predictable value than cold test. So meaning if EPT responds, most of the time the tooth is indeed vital. It's higher than cold test. So if the EPT and cold test contradicts, you should trust your EPT. Okay? Because EPT has a higher positive predictive value, meaning that if the tooth is vital, your EPT will test positive. most of the time. So if these two contradicts, you have to trust your EPT. Okay? But then, like I mentioned, right, because all your EPT and co-test, right, they still rely on the patient's response, the patient's ability to give you the right response as well. So how often are you right? If you collect your history, you already reproduce the symptoms by the patient, how often are you correct? If you diagnose the patient as reversible pulpitis based on your textbook symptoms and your clinical tests, you are right 96% of the time. This is based on the Gucci study. And if it's a case of irreversible pulpitis, you are only right 84% of the time. So meaning that you are not right 100% of the time, because you know that patients do not present with 100% textbook symptoms. They may have lesser symptoms, or they may have variation of symptoms. So that is why you cannot always say that you are definitely right based on your co-test, your EPT, or based on the patient's history alone. You'll be right 96% of the time. You'll be right most of the time. That's correct, but not all the time. So that's something you need to keep in mind. So that's where it comes a validation process. So validation is the final step of diagnosis, which is also the most important step, because validation will actually tell you the remaining 10% that you miss. Like for irreversible pulpitis is 16%, and the reversible pulpitis 4% that you miss. So if the patient presents you with symptoms and you already do a clinical test, so you need to validate why the patient is experiencing reversible pulpitis or why the patient is experiencing irreversible pulpitis. So you need to validate your diagnosis based on what you have collected, all the data that I've collected initially. So I want to share one personal experience. So did you guys, I want you guys to focus on this 2 of 1-5. Do you guys see a lesion there? Can you guys let me know if you guys can see a lesion there?
Yeah.
Yes.
Very obvious, right? There's a lesion there, right? So can all of you agree that there's a lesion there? But then, after I obturated, because I did RCT for 1/6, is the lesion still there? So is there a lesion there? Do you think the lesion is there?
I see it.
Okay, then you know what I've done? I've done RCT because I thought, yes, the tooth is non-vital. I did it without doing anything, you know. I just did RCT straight away. But actually, the tooth is vital. Because when I did access opening, right, there was bleeding. The bleeding was normal. There was no excessive bleeding since, like, signs of irreversible pulpitis, actually. So actually, because I skipped my diagnosis, I skipped asking the patient had no symptoms, I didn't perform co-test or EPT, and I didn't validate the diagnosis. I just look at the radiograph, I just assume that, oh, the tooth is not vital because there's a lesion there. But actually the tooth is vital, so I did an unnecessary root canal treatment thinking, but back then I didn't know lah, obviously. I just thought, oh, okay, lesion there. So this was actually a 1-month review, like, no, sorry, a 1-year review. No, 8 months. Yeah, 8 months review of this patient. I've done the RCT. So yeah, you can see my deep split. But then, I shouldn't have done RCT in the first place for this patient because the tooth was actually vital. I didn't diagnose properly back then. So it was an unnecessary root canal treatment done by myself, from my side, because I didn't diagnose properly. So, and then second thing, this one actually Junwei pointed out to me just last week. For the mesial canal, do you think the obturation is accurate? Like, is it till length or did I extrude it? What do you guys think? You guys think it's on point? Or you guys can't see, just assume that I cannot see because X-ray is too, gamma X-ray is too bad.
The mesial canal?
Yeah, the mesial canal.
Distal.
Mesial.
Oh, distal, yeah.
Just look at mesial. Do you think it's on point or it's excluded?
I think it's on point.
Yeah.
I think it's on point, right?
Yeah.
If anything, I would say it's the distal.
Okay, this was the review. Look at the mesial now. Remember, Kashmir, I showed you this X-ray, right?
Yeah.
The mesial is extruded, right? Remember, you asked me, is it extruded?
Yeah. This is the after, right? It's the review.
Yeah, this is the review appointment.
Oh, there is extrusion.
Can
So I'm obviously extruded, right?
Yeah.
I didn't know also when I obturated. Because so that even X-rays, right, they don't actually tell you the whole thing, because they're prone to so many distortions. Like, you can't tell for sure. Like, how I know I'm actually on point or actually excluded. Or maybe actually the first one is correct, but this one is wrong. I wouldn't know, right? They both contradict each other, technically. So that is why I wanted to say that you cannot skip your clinical tests because something like that will happen. Because X-rays cannot tell you 100% what is going on. So this is a study done by Goldman where they asked 253, like there are 253 cases, right? They let 6 examiners see them. They are all very experienced people, like they're all endodontists or they are at least practicing for at least 10 years. So they're all very experienced people. So even so, they give them 253 cases, they agreed on less than half of the cases, meaning that whether there's lesion or not, whether the obturation is on point, extruded, or whether it's short of working length, they agree on less than half of the cases. So meaning that X-rays, actually, your IUPA, you don't be so obsessed with it, because even if experts can disagree, how about us? Like, I may think that there's a lesion, but you may not think there's a lesion. So that is very common. And they notice that even when they allow these examiners to view the same X-ray at different times, but of course they don't know, because they see 253 cases, they are confused. So if they see the same case at different time, under different lighting, they will also report a different result. So even their intra-examiner variability is very high as well. So even we contradict with our own judgment. So that is why X-rays are not that accurate, because it's very prone to distortion. And also another study by Bender where they noticed that if the lesion is not in the cortical bone, it's not involving the cortical bone, you'll not be able to see it as well. So that is why IUPAs, right? If you ask me whether there's lesion, actually I don't know. If there's a lesion in the cancellous bone, obviously I can't tell. But if the lesion pierces the cortical plate, that is when I will be able to see a lesion. That is why it's very important for us to investigate first your co-test EPT before you take an X-ray. Because what you cannot really fully trust the X-ray, because they are prone to too many distortions as well. Even there might be a lesion, but you might not be able to visualize it. Because if it does not pierce the cortical bone, you will not be able to see it. So this is about this study as well. So that's about X-rays, right? So how about the pulp? The pulp would be the ultimate decider, meaning that whatever the patient say, the history that you collected, the pulp will decide what the final diagnosis is. Okay? So once you see the pulp, that is when you know what the diagnosis is. Doesn't matter what the symptoms are, doesn't matter what you see in the X-ray. The pulp will decide what is going on in the end. So for cases with reversible pulpitis, actually reversible pulpitis is actually a histological diagnosis. What you can see is there will be obviously signs of inflammation, there will be inflammatory cells, that's why, and for the case of irreversible pulpitis, you will see zone of necrosis. So that is the main difference between reversible and irreversible pulpitis. One is just inflammatory cells, irreversible will be zone of necrosis plus inflammatory cells. So that's the difference between irreversible and reversible pulpitis. So we can see this is histologically. Can you guys see this empty space here? You can see my mouse, I'm not sure. You can see, right? So this actually is empty because it's actually the presence of micro abscess. So which was washed away during histological processing. So during this time, you know that this is a case of irreversible pulpitis because this was a zone of necrosis which contains abscess, which is why the pulp is irreversibly inflamed. And this is on the right, it will be reversible pulpitis. You see there's no zone of necrosis. The pulp is still in one piece and the bacteria is still quite far away. So it has not reached the pulp. But on irreversible, you can see it has reached the pulp. And you also have formed abscess and zone of necrosis of the pulp. Then, okay, before I go to treatment, do you guys have any questions to ask me first? You guys want to ask anything before I continue? Or are you guys okay? Then I proceed with treatment.
Can I ask something that's a little sidetracked?
Yeah, sure.
What did you do with the tooth? The X-ray that you showed just now?
Which two?
6.
The 6. The patient is coming back in 3 weeks, so I don't know yet.
So you don't know.
It's about 3.
Yeah, okay.
but I don't know yet. Okay. Anyone? You guys have any questions you can ask now before I proceed to the treatment options? No? Okay, then I proceed.
Wait, I have. So you always sort of like wait, hold on. I don't know how to ask this question, but you just now you mentioned that lesion can only be seen if it perforates the cortical bone, right?
Yes.
So you don't rely on X-ray lah, then like.
Your X-ray is to validate why the patient had a symptom. Okay, it's assuming that you diagnose as does it matter to you whether it's lesion or not actually?
No, it doesn't.
Yeah, it doesn't matter. If you diagnose as pulpal necrosis, you need to do RCT either way.
Yeah.
If it's irreversible bronchitis, you can do it. You can do vital talk therapy, right? You don't need. So does it matter whether the lesion exists or not? It doesn't matter.
Understood?
Because it's not even accurate in the first place.
Yeah.
Okay. Any more questions?
I actually have a question. Like you say tender on percussion test isn't really telling you much.
Yeah.
But that's what we learn by textbook in uni lah. That's extensions until the proper involvement. Then you have PDL. That's why you have the tender on percussions. So why do you say that it's not telling you anything?
I'm saying that it will tell you which tooth is affected, but it doesn't tell you whether you should do a restoration or should tell you do RCT. Right? You don't just assume that once you tap, then the patient has a pain, okay, you need to do RCT straight away.
But does it give you an idea to think that there might be involvements on periapical tissue?
Not really, because even if the patient has pulpitis, right, if you tap, the patient may tell you, yeah, I feel something. So do you judge their something? Like I said, patient's response, right? Patient's response will not be accurate. So you can't really judge their something, right?
Yeah.
So that is why it can supplement your diagnosis, obviously. You can have an idea, but you cannot skip your pulp sensibility test.
You cannot skip like the reproduction, validation steps, whatever, right?
Yeah, you cannot skip. Yes. Exactly.
But it gives you an idea to sort of tell you what to expect, okay? Got it.
Okay, any more questions? No more, right? Okay, then I'll continue. So how do we treat irreversible pulpitis? So what is the goal of treatment actually? Number one, we want to resolve pulpal inflammation. And number two, we want to preserve pulpal health as long as we can. I believe we can agree that's the goal, right? That's why we do a restoration, right? Or do you guys not know why you guys do a restoration? Like why do we do a filling for a patient? Because that's the main reason why. Because when we do a filling, we want to resolve. Number one, we want to remove the source of irritation, right? Because we want to resolve the pulpal inflammation. So that is why we also want to prolong. We don't want the tooth to necrose and die out because we want to maintain the pulpal health. So that is the biological goal of restoration. So when we are doing a filling, that's the only thing we care about. Are we doing these two things? So, which comes to the controversial topic, selective versus total caries removal. Which one do you guys do? In Manipur, I do a lot of selective. I think I remember. Do you guys do selective or you guys do total?
Selective.
Selective. So everybody does selective.
Yeah.
Okay, so which is in for according to ESC, right, the European Society of Endodontology, I think. Yeah, they did say that non-selective caries removal is no longer regarded as a treatment of choice. So when we do selective caries removal, like myself, I used to do it a lot. We are also in line with the guidelines listed by ESC. So we are not wrong. You're not wrong also doing ESC. But if you notice, AAE, they gave a very different opinion. They say that you must do complete caries removal. Because without doing complete caries removal, you won't be able to visualize the pulp. You won't be able to completely eliminate the infective tissues as well. Even some form of caries behind will have pulpal inflammation and it may lead to necrosis later on. So I want to ask you guys, both of you do selective, right? How many of the cases fail? How many of the cases succeed? You guys know?
So far I did two of them okay lah.
Okay, how long is okay to you?
2 weeks.
So 2 weeks is enough for the pulp to necrose? Is that what you're trying to say?
No. I haven't reviewed long enough.
So technically, we all don't know, right? What's our failure
Yeah.
rate for
Yes.
selective or complete caries removal? Because like we didn't review the patient long enough to know that whether the patient has necrose or the patient we don't know what happened to the tooth, basically. So who do we follow, right? I think that's the controversial topic, because for result barbitis we can do either one, caries, selective caries or total caries removal. So I want to show you an example by Rikuchi, right? So Rikuchi performed an selective caries removal. Okay, you can tell that this restoration is very nice, right? I don't think anyone can disagree that this restoration is very good restoration done, right? And even in the radiograph, Rikuchi has given that, look at the seal. It's actually very perfect, right? Like you don't see any voids or something like that. So it's actually a perfect seal onto a caries tooth. Like he left some caries behind over here. There was some form of caries behind. Then he sealed it completely, the restoration. So I think it obeys all the biomimetic concepts as well, that you make sure that all the walls are free of caries, you get a good bonding, you make sure that there are no voids at all. Okay? So even histopathologically, right, he took on the tooth. Look at the seal. It's very nice, right? There are no voids at all, actually, even histopathologically, under the microscope. You cannot observe voids from his restoration. So you can see that it's a very good restoration for selective caries removal case. However, when he took a section of that tooth, he noticed that actually the bacteria are still present. So remember what we learned in undergrad, they say that the bacteria will die off eventually if they're cut off from their nutrient supply, right? That's what we learned in undergrad, right? Rikuchi has proven that this is actually not the case, because like his restoration was very good, and this was after 9 months, I think. So it's actually a long period of time. The bacteria are still alive, and they are still going towards the pulp. You can see that they're actually in the dentinal tubules. So they are still running towards the pulp, and you can see this is actually the bacteria that you can see that it's still active because the bacteria is still proliferating. So the bacteria are not dead. And this is from the pulp, where they notice that these are all inflammatory cells. I think you can recognize like lymphocytes, plasma cells, and all. So the pulp is still reacting. It means there is still an insult towards the pulp. So do you achieve the first goal of restoration if you do selective caries removal, that you want to resolve pulpal inflammation by removing the source of irritation? So if you do complete caries removal, you do selective, right? So that is, Rikuchi has proven that this will happen. That the pulp is still fighting, the bacteria is still present. So do you think that you achieve anything with your selective caries removal? Right? So he also mentioned that those firm dentin that was left behind, they are actually, there's bacteria that are still present. So they say that only infected dentin has bacteria, not affected dentin. If it's firm, then it's fine. Actually, he has proven that is not the case. He said it's a misconception because bacteria can travel into infected and affected dentin both. So actually, if we leave this firm dentin behind, bacteria is actually still present. So that is why they also mentioned that we say that you can cut off the nutrient supply from the bacteria if you get a good seal. He has proven that this is not the case as well, because the bacteria can still gain nutrients from dentinal tubules, dentinal fluids, proteins and glycoproteins, and demineralized collagen from the dentin, and also given up by the pulp as well. So that is why actually the bacteria still have nutrients. It comes directly from the collagen from the dentin. So that is why even though you get a very good seal, the bacteria will not die off. The bacteria will still be alive. So this was actually also supported by Taha study, where Taha has done, they do a randomized controlled trials, right, in two, like, they split into two groups, total caries removal and selective caries removal. So they noticed that obviously total caries removal, there will be more pulp exposure. It's higher, it's 28%. But selective caries removal, right, there's 17.5% of pulpal necrosis that occurred that requires root canal treatment. So this finding also supports what Rikuchi said, that if you leave caries behind, the pulp survival rate will be lower, right? Because you leave bacteria behind, one day the bacteria will reach the pulp. You can't predict when. It could be 1 year, it could be 5 years, it could be 10 years, but one day the bacteria will definitely reach the pulp. Because the pulp is also constantly fighting back. So that is why he claims that total caries removal is better. And you can see that it's quite significantly better in just 1 year. So that is why AAE proposed for everyone to do total caries removal. But again, you can because previously the ESE supports selective because they claim that pulpal exposure themselves is a sign that the tooth may necrose later on. So that's why they prefer not to expose the pulp into selective caries removal. However, there's also a case saying that it's because previously people do restorations without rubber dam. They don't have proper isolation and don't have proper vital pulp therapy techniques. So technically, if you let bacteria enter the pulp, yes, the pulp will die. But what if you can have good isolation and you prevent all that? Logically, the pulp wouldn't die, right? It doesn't matter how you can expose 1 mm, you can expose 5 mm, it doesn't matter. The pulp will survive if the bulb is not contaminated. So that is why are we against complete caries removal if you can do proper vital pulp therapy, right? So my personal take on this would be, if I'm in government sector, I'll do selective caries removal because I don't have rubber dam, like I'm not using rubber dam. And I know if I expose the pulp means the saliva will enter and also it will fail lah. So that's why in government, I'll do selective, but if in the RCT treated tooth, or it's or in private setting, like if I locum, I'll do total caries removal because I'll do it under rubber. So I think that's the difference lah between total and selective. So that's what I will do lah. But of course, you guys can decide whether you guys will go for total or selective caries removal. That is up to you because both guidelines are viable and you guys can decide what you guys choose to do. So if assuming that you guys decide to proceed with complete caries removal and you will expose the pulp, right? And we actually used to say this, that you did not expose the pulp. There was already a functional exposure, so you shouldn't say it's iatrogenic. If you had to remove caries and you expose the pulp in that process, it already has a functional exposure by the bacteria. So you're just cleaning up the bacteria, so you're not exposing the pulp. You are just cleaning up what is left. So if you expose the pulp, how do you validate the pulp, whether the pulp is in a reversible state or irreversible state? You judge based on the bleeding from the pulp tissue. If you use sodium hypochlorite and try to stop the bleeding, it should be able to achieve within 5 to 10 minutes. If the bleeding is continuous, means you know that the pulp is in an irreversible pulpitis state and you have to remove the pulp, or at least part of it. So that is what people use. People use sodium hypochlorite for this case. So a summary for reversible pulpitis would be, if you do caries excavation, if there's pulp exposure, you have to arrest the bleeding with direct pulp capping with empty or bioceramics. So the normal bleeding will be arrested using sodium hypochlorite. But if you cannot arrest the bleeding, you have to do a partial pulpotomy, meaning you have to remove portion of the pulp and then observe for bleeding again. If the bleeding can be controlled, then you can proceed with your pulp capping. So it doesn't really matter the size of the exposure actually, but it only matters how you handle the exposure. And if you proceed without exposure, then obviously you can just restore it. So that's a summary for reversible pulpitis. So do you guys have any questions for now? Or reversible pulpitis? You guys have a question? So you guys understand everything, right? So it's okay. If okay, then we will proceed to the next one. So the second one will be irreversible pulpitis. Is root canal treatment actually necessary now for irreversible pulpitis? Is it still the case? So we can see the goals of irreversible pulpitis would be, number one, obviously remove the source of irritation, removing the zone of necrosis, and we to have to preserve what is left, if possible. So we want to remain we'll be as conservative as possible, but we must remove the zone of necrosis because the zone of necrosis is irreversibly damaged, like I mentioned in the pathological section. So that's what we need to do for the treatment of irreversible pulpitis. We need to remove the zone of necrosis, the source of irritation, and preserve as much as possible. So is RCT required? Now Taha has showed a study as well that they do partial pulpotomy on patients diagnosed with irreversible pulpitis based on their clinical symptoms. So they noticed that the survival rate is also actually very high. If the group uses MTA, the survival rate is actually 83% or 85%. So it's actually a viable option to perform pulpotomy on irreversible pulpitis. So pulpal necrosis is not, root canal treatment is not the only option for irreversible pulpitis right now. because we have other options. Logically, if you remove the zone of necrosis, the tooth should heal, right? Histopathologically. So that is why the question should be how you know that you have removed the zone of necrosis. Is when you observe the bleeding of the pulp. So logically, you don't need to do a root canal treatment for cases with irreversible pulpitis. So even Duncan has mentioned before that if the pulp cannot be arrested, the bleeding cannot be arrested within 5 minutes, that's when you need to do a full pulpotomy. Because even the ESC supports that you don't need to do a root canal treatment for cases of irreversible pulpitis. You can proceed with a pulpotomy, and it will work as long as you remove the zone of necrosis. So both guidelines support this treatment option. Then the summary of this would be very simple, is if you must remove the source of irritation for sure, with complete caries excavation, and you do a pulpotomy on the zone of necrosis. Then if the bleeding is arrested, then you can add your bioceramics, your MTA and all, and restore the tooth. But if the bleeding cannot be arrested, you can go one layer deeper and to see if the bleeding will arrest. The lowest you can go is until the orifice level. If beyond that, you should just proceed with root canal treatment, meaning the irreversible pulpitis are extended completely until the root canals of the tooth. So that is when you need to do a complete extirpate of the pulp. That's why you need to proceed with root canal treatment. So that is the summary of irreversible pulpitis. So obviously I learned all this from Dr. Imran during his diagnosis course. So that is when it's a 2-day course where I learned everything about diagnosis from him. And if you guys happen to drop by Kuantan and he's making it first, you guys can go and try out, because I think it's very worth it actually, because I think diagnosis is actually the most important thing when we treatment plan. So do you guys have any questions? I think that's all for my presentation. You guys can ask me any questions, I'll be happy to answer them. You guys have any questions?
Darren, that if you say leaving caries behind is, I mean, total removal is better, right? Then indirect
Yes.
capping is basically useless lah then.
Wait. Sorry, come again.
Then what are your thoughts on like indirect pulp capping?
Why do you need indirect pulp capping actually?
Why?
Yeah, why do you need indirect pulp capping? Like in which scenario do you need indirect pulp capping? You mean when you leave caries behind?
Yeah. Yeah.
So if you do selective caries removal, right? Why do you need to leave? So you mean in the case of irreversible pulpitis? Wait. Sorry, Julian, come again. You mean when you are doing selective caries removal, you want to leave the caries behind and put biodentin or something?
Yeah, calcium hydroxide in government lah.
Okay, so you want to hope that the pulp will produce dentin. Is that what you're hoping for?
I guess.
Okay, so based on what you say, right? Number one, like how long do you think that it will take for dentin to form?
I don't know.
Because like it's not predictable, right? Like in Rukuchi's study, usually like 1 to 2 months, but basically he did a full pulp exposure as well. So that's when he exposed the pulp, he put your MTA and all, then he put bioceramics and all that. So actually what you say is true, it can work. Because if you put all these biodentin and all, right, but it must have direct contact to the pulp, otherwise it wouldn't help, right, technically, right? But you must remove the source of irritation. So if you don't remove the source of irritation, the bacteria can still progress. So I see it as like gambling if you don't remove the caries completely. Because it can go either way, right? You leave the caries behind, the caries can still progress. But if you don't, if you put all your bioceramics, or you are hoping that it will regenerate, but then there's no contact with bioceramics to the pulp, right? So how can it stimulate regeneration of the pulp? True, right?
Yep.
So that's why I don't see a place for indirect pulp capping. I only see it as pulpotomy and either a full pulpotomy or direct pulp capping. That's when I will do it. Do you have more questions? Do you have any more questions?
Really, no. Not me.
Okay. Christian, do you have any questions? Or anyone has any questions? Anything? Oh, Shamey just joined. Shamey is not a different link, right? It's the same link, actually. Is it different?
Hello. I don't know, maybe it's a glitch. Sorry.
Oh, actually, okay, Shamey joined 2 minutes ago. Okay, you guys have any questions? If not, I think we can end here. Sorry, Shamey. Finish already. Christian, I thought you had a lot of questions, huh, you say? I'm excited for your questions, actually.
Not really related to this one, actually.
So,
I just did like a few cases and then I want to ask you.
sorry?
I just did a few cases that I wanted to ask you, but then not really related to this. Yeah.
Oh, okay. So that so for the rest of you, if you guys still want to join, you guys let me know lah. You guys find this helpful or not, because it's something we're still experimenting, and next month I think Kershwin will present, right? Kershwin will present on vertical dimension, right? I think.
Yep. But I wouldn't say it's like this.